This video is going to be on valvular pathologies and heart murmurs. We'll start with valvular pathologies, things that affect your valve. And the first one we're going to talk about is infective endocarditis. Judging by the name, you have some sort of infection that affects your endocardium. That's the inner layer of your heart. That's what lines your valves. And we can break this into whether or not the bug is high virulence or strong, or low virulence, a little bit weaker. All right, high virulence bugs cause acute infective endocarditis, cause acute symptoms because they're so strong. The one we're usually thinking about here is Staph aureus, because Staph does it all, right? Staph's just the worst. Hashtag Staph is the worst. It causes this acute infective endocarditis, acute symptoms, and it's so strong that it can affect normal valves. Normal valves. It loves to affect, in particular, the mitral valve. The mitral valve. There's one exception, and that is in IV drug users. When they inject into their veins, well, blood will return into their right heart. And the first valve it hits is going to be the tricuspid valve, right? So IV drug users think tricuspid. That's the exception that you should know. Let's talk about our low virulence. Our low virulence, these are weaker bugs. All right, they cause less acute symptoms, a little bit more indolent, a little bit more chronic symptoms. This is going to be our friend viridans, strep. All right, and because it's so weak, it needs to affect damaged valves, valves that are already weakened on its own. It can't affect normal valves; it's too weak, so it affects damaged valves. Now, this group is found in your mouth. All right, so sometimes the history will talk about someone with a dental procedure, and maybe they cut the gums or cut their teeth, cut their gums or cut the inside of their mouth, and that allowed bacteria to go in. And so they'll give a history of someone that underwent dental procedure and then showed up with signs of infective endocarditis. Okay, that's how they like to ask that. There are some other bugs that can cause infective endocarditis. They'll be in my notes, and that don't grow up in culture. We call those culture negative bugs. So just have a glance at them, make sure you're able to recognize them on an answer choice. But some special ones that you do need to know that I'm going to write down is going to be group D strep, aka strep, gallolyticus. Why is this important? Because it's seen in patients with colon cancer. How do they like to ask this? Well, they'll talk about some of signs of infective endocarditis, which we'll talk about in a second. And then you culture the blood. You culture the blood and you grow out strep gallolyticus. What's the next thing you do? Colonoscopy, because they might have colon cancer. Another very important bug you should know, Strep epidermidis. This strep can make biofilms, and that makes it very easy to cling onto prosthetics, prosthetic valves. Right, so history will give someone with a valve replacement that has infective endocarditis. What bug do they have? Strep epidermidis. That's the way they like to ask those questions, okay? So we talked about signs of infective endocarditis. What are the actual signs? They love the physical exam finding for infective endocarditis. That's going to be your painful osler nodes, that's going to be your splinter hemorrhages, that's going to be your janeway lesions, all this stuff. A full list will be in my notes. Just be careful. Sometimes they ask it a little bit weird. They're not going to say a patient comes in with an osler node. All right, they don't do that because patients don't do that. They don't say, "Hey, doc, I have an osler node." All right, they'll just talk about a painful nodule, splinter hemorrhages, these red line-like marks on the fingernails, janeway lesions, small demarcated erythematous, blah blah blah, all this stuff. So they'll try and help you and give you the answer, but they can't just straight up tell you. So just be aware of that's how they might ask it. But if you know the physical exam findings for infective endocarditis, I think you'll be all right. You can have sterile endocarditis. You have sterile endocarditis, so inflammation of your valves that cause these vegetations, but they're not from bacteria. They are non-bacterial. That's why I call it sterile. All right, so some non-bacterial causes, you can see them in cancer. They grow these little growths on the valves, and that can break off and cause embolism. And one that they love is Libman Sacks, which is seen in lupus. It's not bacterial because it's not an infection. Lupus is not an infection, it's autoimmune, right? And the big thing they want you to know about Libman Sacks endocarditis is it affects both sides of the valves. You're gonna see vegetations on both sides. They might say anterior, posterior side. That's just a fancy way of saying both sides. So let's try and make a step-like question. How might they ask this? They'll show you a picture of vegetations on both sides of the valves, and then they might ask, what do you find on physical examination? Maybe that malar rash, right? The classic lupus rash. Or they might say, what might they say? What are some lab findings? What are some lab findings for lupus? Okay, so many ways they can throw it at you. If you know the factors and the variables and all the information about lupus, they can trick you. That's infective endocarditis. Our next one is going to be rheumatic fever. Rheumatic fever is a complication of strep throat. Rheumatic fever from strep throat. That's your strep pyogenes, right? But they don't say strep pyogenes, they say group A beta hemolytic. Same thing. And your bodies will make antibodies against it. And that can go a little bit awry. So it's a type 2 hypersensitivity. We're making antibodies against this. And it can go awry. How can it go awry? Well, strep pyogenes has something called M protein. And we attack M protein. That's good and all. However, M protein looks a lot like other proteins in our own body. Like proteins in our joints, in our brain, in our heart. Okay? And it can cross-react and attack these proteins, our own proteins. We call that molecular mimicry. What a great word, mimicry, right? It mimics the things in our own body and we attack it. Molecular mimicry. And when we attack it, we get the signs of rheumatic fever, right? So you get joint pain, migratory polyarthritis, causes joint pain. Why do you think they call it rheumatic? All right, rheumatology is the study of joint disorders and joint pain. So that's why I call it rheumatic. Can attack our brain and damage our basal ganglia. You get Sydenham chorea. Can attack our heart and you get pancarditis. That's inflammation of all the layers of your heart. All the layers. What are the layers of your heart again? You got 3 layers, right? Your endocardium, your muscular myocardium, and then your epicardium, which was basically part of your pericardium. Right? So it can affect all 3 layers. It can affect your endocardium and affect your valves. So endocardium, valves. And kind of like infective endocarditis, it likes the mitral valve the most. But it can affect your aortic. All right. And initially it can damage your valves and they can't close and you get blood leaking in and out. So you get mitral regurgitation. But eventually it damages so much and for so long you start to get stenosis and fibrosis and you get mitral stenosis. It's all right, late. It's a late complication. You can't get like immediate stenosis, that doesn't make sense. So it's a late complication. All right, it can affect your myocardium, that's your heart muscular layer, that's what helps you contract. And if it damages that enough, your heart can't contract, you die. That's actually the most common cause of death. So myocardium equals most common cause of death. Can affect your epicardium, aka your pericardium, causes pericarditis. That's your pain on inspiration, friction rub, all that stuff. Pericarditis. All right. Some other things it can affect your skin, cause skin nodules. It can affect and cause these red marks that have kind of a margin on them. We call that erythema marginatum. A picture will be in my notes. But these are the ones that you really, really gotta know. And if you biopsy the heart, you're gonna see macrophages making granulomas. All right. I don't know what I'm drawing. I don't know what this is, but you're gonna see granulomas, okay? You're gonna see granulomas. Some jerk wanted to get his name in writing and just called it Aschoff bodies. It's just a granuloma. Okay, it's just a granuloma. If you see it in the heart, you see this granuloma in the heart, and you see all these signs, rheumatic fever. If you look deeper in the granulomas, what make up granulomas? Macrophages, right? You'll see macrophages, and they have this kind of squiggly nucleus. We call this Anishkoff cells. Anishkoff cells. Okay, but I mean, this is a heart biopsy. You don't heart biopsy everybody unless they're dead. So is there a less invasive way of saying we have rheumatic fever other than clinically? We can give lab testing looking for this strep infection. We can do anti-streptolysin O. Streptolysin O is something seen in strep, so we find antibodies against it. We know we had a strep infection. Another one is anti-DNase beta titer. Right, another kind of strep test. So if these are positive, we know we had a strep infection. Mix it with our clinical signs, rheumatic fever. Rheumatic fever. That does it for the valvular pathologies. Let's talk about heart murmurs. Heart murmurs. Your valves only do two things. They open and they close, right? If there's a problem with opening, if they're not able to open, then it's called stenosis. They can't open. They're stenotic. Stenosis. If it's a problem in closing, if they can't close, then blood will be able to leak back and forth. Regurgitate. We call that regurgitation, right? Problem in opening, stenosis. Problem in closing, we call that regurgitation. Let's break it down into systole and diastole. All right, let's look at murmurs in systole. Let's look at murmurs in diastole. In systole, let's draw it out. Here's the right atrium, right ventricle, left atrium, left ventricle. This was our tricuspid. This was our pulmonary valve. This was our mitral. This was our aortic, right? In systole, your ventricles contract, blood gets pumped out of your pulmonary and your aortic. So your aortic and your pulmonary open, right? And when they contract, they will pull these valves close with their chordae tendineae. Pull it closed. So your mitral and your tricuspid valves close. That way you don't get blood leaking back. So mitral, tricuspid, closed. That's what happens normally. But we're not talking about normal here. We're talking about murmurs. So there's a problem in this opening. There's a problem in this closing. What do we call that? We call it aortic and pulmonary stenosis. We call that mitral and tricuspid regurgitation. All right, so that's what you see in systole. Let's talk about this first. No one cares about pulmonary murmurs. I've never seen a question in pulmonary murmurs. I don't know why. I feel bad for pulmonary valves all around the world, but they don't care about it. They just care about aortic stenosis. So aortic stenosis. Normally we're supposed to open it, but there's a problem opening it. We call it aortic stenosis. All right. Very common, seen in elderly. Over time, your aorta, which just works over and over, gets worn out, gets calcified, gets stenotic. So you see it in elderly. If it's a younger patient, then you're thinking they might have a bicuspid valve. It's all right, younger. If you have 2 leaflets in your aortic valve instead of 3, it has to work that much harder. So it gets calcified that much sooner in a younger patient. And if it's stenotic, you can't open it, you can't get the blood out, you get syncope. Syncope. Cool. Cool, cool, cool. How does it look like? Wait, I don't know why I said how does it look like. You can't look at a murmur. How does it sound like? If this is S1 and this is S2, you will, and there should be no sound in between. Well, here we have a murmur, right? You will try and eject blood out of that aortic valve until you finally are able to pop it open. Pop it open. And then after that, it relaxes. All right, so it's called a crescendo decrescendo. For all our musically inclined people out there, that means louder and then softer. So it gets louder and then softer. And as blood blows past your aorta, it'll radiate to your carotids. Radiate to carotids. Radiate to carotids. That's it. Let's talk about our mitral and tricuspid valve. Normally they're closed, but we're not talking about normal here. So if there's a problem with closure, we call that regurgitation. So in Sicily, we have mitral and tricuspid regurgitation. Mitral, tricuspid, regurg. Mitral and tricuspid regurg. All right, you can hear it. Here's S1, S2. If these are open, then when you pump blood out in systole, blood will leak through. Blood will leak through. And so you just hear the blood leaking through. Mitral murmurs are best heard at the mitral area, right here, and it'll radiate to your axilla. Tricuspid, heard at the tricuspid area. Easy peasy. What causes that? We already talked about what causes mitral damage. We talked about infective endocarditis, rheumatic fever. We already talked about what causes tricuspid damage. IV drug users. So look for that in the history. I think that's all I want to say about that. Now there's a special case of mitral valve regurgitation called mitral valve prolapse. What in the heck is that? That's when your mitral valve is super floppy. Super floppy. And here's my prop. Normally in Sicily, it's closed, right? But here our mitral valve is super floppy. It's still closed, but it's super floppy. And so when you contract, you push blood out, it'll feel that blood pushing against the valve, and it will poof up like a parachute. It'll poof up, and then it'll relax back to its closed position. And if you contract, again, it'll fill that blood and it'll poof up. This is not working. It'll poof up and then it will relax. Okay? That is mitral valve prolapse. How does it sound? Here's S1, S2. You'll contract and blood will start to push until it poofs it up. So you get a click, you click. When it poofs up, it clicks, it snaps like a parachute. When you throw it up, it'll snap open. You get a little click, and then it will relax. So I'll say mid-systolic click. Now it can be seen in mitral damage, like in rheumatic fever. It can be seen in connective tissue disorders, like Marfan's, Ehlers-Danlos, because you get a fancy word, myxomatous degeneration. Your connective tissue is degenerated, right? It's not as strong, so you don't get that nice strong valve. You get that floofy parachute-like valve that pops open and then relaxes. All right. There's one more systolic murmur, and we'll be done with systolic murmurs, and that's VSD. It's a hole between your ventricles, a connection between your ventricles. All right. So when you're contracting and you're pushing blood will move between this hole and cause a murmur. Cause a murmur, systolic murmur. That's it. That's all you need to know. The complicated thing is that VSDs are best heard at your tricuspid area. And it sounds just like a tricuspid regurg. How can you tell the difference? Well, who gets VSDs? It'll be children, right? Little kids. Little kids have VSDs. Who gets tricuspid regurg? IV drug users. So unless a 3-year-old is shooting up, the history will be completely different. All right. So you listen to the tricuspid area, you hear the systolic murmur in a 3-year-old VSD. You listen to the tricuspid area, you hear this systolic murmur in an IV drug user. Tricuspid regurg. Done deal. That's systolic. Let's talk about diastolic. Let's reset all of this mess. Goodness gracious. Okay. Reset. In diastole, what happens? What happens in diastole? Well, in diastole, your heart relaxes. All right? Your aortic and your pulmonary valves are no longer getting pushed. They relax, they close. They close. Blood will return, start filling up your heart, eventually pop open its valves. So your mitral and your tricuspid valves open. Open. Problems in closing, we call that regurgitation. So here we get aortic and pulmonary regurg. Unfortunately, we don't care about pulmonary valvular disorder, so we get aortic regurg. Mitral and tricuspids open. Problem in opening, called stenosis. Okay, couldn't be simpler. Let's talk about aortic regurg. In aortic regurg, if your aorta can't close, blood will leak back. You hear a sound. So here's S1 sound, S2. You hear a sound in diastole. You hear that blood leaking back. The bad thing about that blood leaking back is now your left ventricle is overfilled, and it will pump out more blood the next time it contracts, the next systole. And that increases systolic blood pressure. Do you remember our talk on pulse pressure? Way back when, a few blue moons ago? We said that was basically your systolic pressure minus your diastolic. Right? And if you increase your systolic, then you increase your pulse pressure. Well, if you're having blood leak back and you're getting overexpanded, you're pushing out more every time you do systole, then you increase your systolic pressure. Right? So you have increased pulse pressure. You have such increased systolic pressure that you get bounding pulses. You feel the pulse and it's just beating really, really hard. Right? They might have head bobbing from how hard that blood is beating. If you look at the uvula is like pulsating from how hard that blood pressure is. So that's increased pulse pressure. That's something you should know. Eventually, your left heart can't work anymore, right? You're stressing it out so much, you get left heart failure. Left heart failure. Done with that? Let's talk about mitral and tricuspid stenosis. Mitral and tricuspid stenosis. So these are stenosed. They can't open. Blood's filling, but they won't open. They won't open. They're stubborn until they finally pop open. They're stenosed. So here's S1, S2. They're filling, they won't open. They're stubborn until they finally pop open. So there's a little space in between where you're waiting for them to open. We call that an opening snap. Where they finally pop open, we call that an opening snap. So blood is filling, and it's not opening. Eventually, it'll dilate your atria. You can imagine if blood fills and it's not opening, then it'll dilate your atria. Atrial dilation. Here's kind of the neat thing. Eventually, your atria will dilate so much that it will pull your valves apart, and it will no longer be stenotic. Pull your valves apart, and it will no longer be stenotic. And so this opening snap gets closer to S2, right? It can open much easier now because your valves are being pulled apart. If it gets closer to S2, then that means it is long-standing. That means it is worse. It is worse. Your hearts are so dilated and full of blood and has been going on with this stenosis for so long that it's just dilated. It's huge. So the way they like to say it is, if there's a decreased snap interval, that means it's worse, increased severity. Okay. That is, I think that does it for, no, that doesn't do it. Sorry, I got you excited. That doesn't do it for the murmurs. We have one more, PDA. PDA connects your pulmonary artery to your aorta, and so anytime you pump, no matter what, you get a murmur, so you get a continuous murmur. That might be the easiest murmur to recognize. You just have a murmur all the time. Murmur all the time. Where do you hear it? Well, the best way you hear it is not actually in your 4 heart regions, but actually under your left clavicle. So left infraclavicular. Okay. Associated with prematurity, associated with low oxygen content, associated with congenital rubella. That is your murmurs. And that's a lot of information. And they all seem somewhat similar. How do you tell them apart? One of the easiest ways, and the way they test you on the test, they'll show you a diagram of someone's heart, and you can listen to the different areas, all right? So if it's louder in one area, then it gives you a clue, right? If it's louder in the mitral area, then it's probably a mitral murmur. If it's louder in the aortic area, probably an aortic murmur. So that's one way to test you. Another way to test you is with maneuvers. You do different type of maneuvers that can increase or decrease the intensity of these murmurs. Let's talk about the maneuvers. Maneuvers. Okay. You can increase the preload of your right heart. How do you do that? Just take a deep breath. Take a deep breath. Blood will drain back into your heart, into your right heart. If you have more blood into your right heart, it just increases the intensity of the murmurs of right heart murmurs. Increase intensity of right heart murmurs. Right? If you have problems opening, then more blood will try and get through that stenotic valve. You have increased murmur. If you have problems closing, then more blood will be able to leak back and forth. You get an increased murmur. Right? So it just increases the intensity of any right heart murmur. But let's talk about outside your right heart. If you just increase preload volume in all your heart, just general increased preload. How do you do that? Well, you can do that by squeezing your hand really, really hard. Increase hand grip. And that causes muscular contraction, vasoconstriction, stops blood from going there. I mean, if we do a really extreme example, let's just say I tied a tourniquet and I stopped blood from going there. So blood can't go there, it gets stuck in my heart, increased preload. Another way is squatting. Squatting. That's another basically increased resistance. Blood can't go there, stays in my heart. So that just increases preload all around. What does that do? It increases all the murmurs. Increased murmurs. All right. So all right, hand grip and squatting plus squatting. All right. So that's increased preload. How about decreased preload? Decrease preload. Decrease the amount of blood going to your heart. We can do that by standing up really quick and then gravity will drain blood down. We can do that with Valsalva maneuver, basically blowing against a closed airway, and that increases intrathoracic pressure, blocks off our blood vessels, stop it from returning to our heart. So we can decrease blood in our heart. What does that do? That decreases murmurs. If you have problems closing, if you have regurgitation and you don't have any blood, then there won't be blood going back and forth, won't be a murmur, right? If you have decreased blood going through that stenotic valve, stenosis, you have less of a murmur. So it just decreases your murmur. Hopefully that's not too bad. So all right, Valsalva and standing. Cool, 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 cool. Now there are two more tricky murmurs that don't really fit in this category. So first things first, rest in peace, Uncle Phil. Second thing, let's talk about mitral valve prolapse. Mitral valve prolapse, we said, had that little opening click when you, where's my prop? When you contract and it poofed up, right? It had that little opening click. If you increase the amount of blood in your heart, then it will contract, and it takes a while to push that blood, that excess blood, against your valve and poof it open. So increased blood will increase time till click. So initially it looks something like, all right, click, this. Well, if you have increased blood and it's filling and it's trying to push all the excess blood, it'll just take a little bit longer for it to poof up. So now you have an increased duration until you hit the click. Decreased preload, you don't have any excess blood, you contract, it's quick, you poof up your little parachute valve, you have a very early click. So early MVP click. S1, S2. So now it looks like that. All right, so it's an earlier click. And then our last kind of murmur that doesn't really fit in this category, it's going to be our hypertrophic cardiomyopathy. If you want the easy way to remember it, hypertrophic cardiomyopathy does the opposite of your regular murmurs. So here, an increased preload, increased blood, we said that increases the intensity of all your murmurs. And hypertrophic cardiomyopathy decreases the intensity. Here in decreased preload, decreased blood, we said that decreases the intensity of all your murmurs. Here in hypertrophic cardiomyopathy, it will increase it. If you're curious to Hawaii, let's see. Right atrium, right ventricle, left atrium, left ventricle. You have this thickened hypertrophied wall. And when this whole giant wall contracts and tries to push blood out, it will pull in on itself and the mitral valve will collapse and can kind of obstruct outflow. Sometimes we call it hypertrophic obstructive cardiomyopathy. Well, when we increase preload, increase the amount of blood coming into our heart, then we can stretch this, give it some room. And so when it contracts, it won't collapse in on itself, pull the valve in on itself, cause an obstruction. And so the murmur decreases. Here, if we have decreased amount of blood in our ventricles, then it will collapse on itself, right? It has nothing to stretch it out, it will collapse on itself, so the murmur increases. So that does it for murmurs. Hope you enjoyed the video. Thanks.